Okay. So Riley wanted me to be reminded of the signs of hypoxia. Signs of hypoxia. Well, the sign of hypoxia must be something I can measure. Is that not what a sign is? It must be measurable. Can I measure color? Yeah. It's observable, isn't it? Color is observable. Matter of fact, a lot of chemical reagents use color to tell you how much chlorine's in the pool, right? Using color. It assigns a number. So I can use color as a sign. I see it. Symptom they have to tell me. So one of the signs of hypoxia, obviously, is cyanosis. Cyanosis. With rare exception, cyanotic people are hypoxic. There is a small group of people in the Midwest who are blue due to genetics and nitrates. We call them Smurf people. They're just normally that way. It's normal for them. But for most part, cyanosis is bad. Dark-skinned individuals, you have a much harder time seeing the cyanosis. But if you'll pull down the eyelids, the mucous membranes, look in the lips, look at the tongue, you can find cyanosis. Look at the nail beds. What other sign? Oh, pulse oximetry reading. I mean, if you can put faith in your pulse oximetry reading, anything below of 94 is hypoxic. That's not a sign. So I'm going to move to that category here in a minute. Yes, that would be one of them. That's about all that's observable to the EMT. In the hospital, they can pull blood and measure the amount of oxygen in the blood, and that is the surest sign of hypoxia. But beyond that, we're kind of limited. Now, Jonah mentioned they're in a drunken-like state, or another way of saying that, they have an altered mental status. Now, that's going to be kind of on the edge of sign and symptom. I guess I'll give you some leeway there, Jonah. I kind of jumped too early. I'll see the altered mental status. They will express altered mental status as well. So that one's kind of tricky. And boy, it can be so subtle. It's almost like the family member that's around them every day goes, something's just not quite right with her. She's a little off today, a little slow to respond. And that may be something you notice. And you ask Margaret her sample history, she's just kind of slow to respond to you. Forgetful, agitated, anxious, all those things that you can imagine if you were being suffocated. Are they pissy? Yeah, they're often just got a general bad attitude. They got a bad outlook on life, and that can be exacerbated to where they're actually angry at you. Kind of got an idea? There are some cases that are so bad you'll just say they're hypoxic. Like if they're not breathing. I mean, they're not breathing. So guaranteed, what are they, Luke? They're hypoxic. They're not breathing. What if they have ingested, by some weird reason, cyanide? Cyanide poisoning. They're hypoxic. So some things are just absolute. What if they were found unconscious in a camper trailer with a generator running inside of it? They're hypoxic, aren't they? The CO won't even allow the oxygen to get on the hemoglobin. So some things are just definitely hypoxic, Riley. Some things are a little more subtle. But when in doubt, consider them to be hypoxic. If you just can't decide, just go with hypoxic and you'll be safe. If I give oxygen to a hypoxic patient who's also on something called hypoxic drive, I must monitor the respirations. But guys, that's true for any medicine I give. We get over into paramedic school, you got 55 medications or so that you have to learn. If I give you the medication, my number one rule after that is monitor for effects. reassess the patient. Don't treat oxygen any differently. If I give it, monitor for the effects. What do I expect to see when I give you oxygen? And reassess and get a new set of vital signs to see what changed now that I have given you the oxygen. You have to know if your interventions are effective. So we're still in the introductory phase of this, and we'll finish it up tomorrow, so don't freak out that we didn't get there. A lot of this we already know. I think we know what normal breathing is, but I also told you to take that into context. Is it normal for the circumstances? It's normal to breathe 30 times a minute if you've been running. It's normal to breathe 8 times a minute if you're asleep. With associated signs and symptoms, then those numbers matter more, okay? Think of that. Or deal with that as you go through it. Real quickly, what causes abnormal breathing? We already know this. Because you were so studious in the last 2 weeks, you already know a lot of this. We know that if we increase the alveolar gap, if the gap between the capillary and the alveoli is too big, Gus says diffusion has a hard time taking place. Lack of perfusion from the right side of the heart. We talked about that yesterday. We got into a pulmonary embolism issue. We also talked about that being a VQ mismatch. That'll cause abnormal breathing. Fluid, blood, or pus in the alveoli. Pulmonary edema. If alveoli are filled with fluid, they are now classified as dead space. So I know you feel like you've just been hammered, but look what it does for you. So let's put our hands on the patient for a moment. Let's assess someone for adequate breathing. One of the methods we're going to use is a term called auscultation. Auscultation means to listen. We use our ears to do that, okay? We're auscultating breath sounds. Oftentimes we can use or will use a stethoscope. And I got some slides here to show you how to do it. Sometimes I don't need the stethoscope. I can hear this at the 30-foot assessment when I open the door. Has anybody ever seen somebody have an asthma attack? Can you hear it? Do you need the stethoscope? Has anyone heard anyone with congestive heart failure where they got crackles in their lungs? It sounds like they're breathing through a bucket of water. Yeah, you don't need the stethoscope. Heard anybody choking on something? Well, I don't really hear anything there. Ooh, that's bad. Make a little note somewhere. Right now, in your notes, make this note. Put an asterisk beside it and big highlights. A silent chest is a dead chest. A silent chest is a dead chest. Meaning I should hear some sounds, even if it's normal. So we classify our sounds into normal sounds and abnormal sounds. During our labs, we will listen to each other's lung sounds, so we know what normal is versus abnormal. I like to have a systematic way of doing it. If you've ever been to your doctor and he or she listened to your lungs, they have you take that deep breath in, they move it and take a deep breath in. It's just their system. So the diaphragm of your stethoscope is the side that's got the flat piece on it. The bell, the other side's called the bell, and you hear different heart tones and stuff with that. So we use the diaphragm. And let's look at this guy for a moment. We're listening in the front, mid-clavicular, second intercostal space. What the heck is an intercostal space? The second rib right here. And then underneath that second rib is the next space, third rib, third intercostal, on down. But let's just look at him for a moment. Just look at him. Christian, what do you see? An old man. What if I told you he was 38? He's not doing well in life, is he? What do you guess him to be age-wise? 60? 70? Actually, what if he did tell you he was 50? He's had a hard life then, hasn't he? He's aged early, prematurely. Just a contextual thing, isn't it? What else do you see besides an old man? What makes him old? Christian? Loss of muscle tone? Malnourished? His what? What about his neck? Wrinkled up, got prominent neck veins. You can see his sternocleidomastoid. Does he look like he smokes? You knew that without being trained. Because it's just through behavior, right? You see smokers and you see what they look like. Need some protein. He's got the tattoos, not necessarily meaning that tattoos are an indication that he is smoking, but I'm guessing he's an old Navy vet. I'm just guessing. Profiling is wrong. Profiling is often accurate, though. You know, we got a bad deal in our PC culture where we can't profile anyone, and I understand what they're getting at with that. But when it comes to patient assessment, profiling just comes with it. It's just natural to come with it. And I don't make any false assumptions, but it kind of gives me some clues in my assessments, right? You said this guy smoked and you didn't even talk to him. That's profiling. Okay, whatever you want to say. What if he didn't smoke, but you found out that he was a industrial worker who worked around asbestos? And now his breathing difficulty is not due to smoking, but due to asbestos exposure. Most of those people have died, by the way. It's going to be rare you find someone still suffering from asbestosis. Most of them have died since they removed asbestos from the environment. But I can remember still seeing a few of them. And you swore they were smokers, but they were just asbestos exposure victims. He's not really barrel-chested, not at least from this video or this picture. I don't see a barrel chest. Good observations, y'all. He just doesn't look happy either, does he?
But he does it begin like that cocaine chest.
Yeah, it's like he's been tugging at it or something.
It's got an amazing hairline.
An amazing what?
Hairline.
So we're auscultating. We're using the stethoscope. Little point on these stethoscopes. I don't know what the one came in your bag looks like, but if it's got 2 lumens or 2 tubes, I don't like those. Because when those tubes touch each other or bump around with each other, you'll hear it. I like the single tube stethoscope. So if you're gonna go out and buy your own, make sure it's got a single tube. Okay. So midclavicular lines. So there's the clavicle. In the middle of that, we have an imaginary line drawn down, and those are what we call midclavicular. I do a left-right. Now, what do I expect to hear here during a phase of respiration? Do I expect to hear something? Yes. Let me note right now, if you hear nothing on one side, signs of a pneumothorax. You need ALS intervention right now. Didn't get very far with him, did I? I just took a quick listen and went, partner, listen to this lung. Don't tell them why. Well, you'll give them a preconceived idea. If I tell you that hamburger tastes good, you're likely to say, yeah, it does. If I say, taste this, you're like, it probably tastes like crap. That's why you want me to do it, right? You get my point. Don't give them ideas. Listen to this. Tell me what you hear. I don't hear anything. I didn't either. Second opinion, we hear nothing. This guy needs to go quickly? Is he now sick?
Yes.
Because he has no air movement on that side, and I just told you a silent chest is a dead chest. I expect to hear some whispery, breezy air or air movement, and that's hard to describe. It's best that you listen to each other when we do lab, and you'll know what I'm expecting to hear. Yes.
Remind me what a pneumothorax is.
It's air outside the lung. It's air trapped in the pleura space.
Can it be fluid too? Or what's the fluid?
It could be fluid, could be blood, and that's called a hemothorax. Then I'll turn the old boy to the side, or I'll move around to his side. Yeah, he is thin, isn't he? And I will listen to mid-axillary. So the armpit's called the axilla, and a line that's drawn down through the axilla divides the body in the front and the back, or the anterior, posterior portions of the body. And I'm going to listen there. And then I'm going to turn him around, and I'm going to listen on his back, mid-scapular. Now, your physicians during physical exams and stuff will probably get a little more pinpoint, but this is like a quick, doesn't take very long to do it. Silent chest, not silent chest, bad sounds, no bad sounds. That's kind of all I'm going for. Do I hear something? Yes, no. If yes, is it normal or abnormal? That's it. We note this. He probably needs to see a dermatologist too. That looks bad. So the question was, do I hear something? Yes, no. No is bad. Silent chest, dead chest. Yes, good or bad. Kind of like a flow chart, isn't it? So what are bad breath sounds? These are bad breath sounds. Wheezing. You really need to pay attention to this because the National Registry will use 3 words to describe breath sounds, and one of the words they use is wheezing. Wheezing equates to, you can put wheezing equals in your notes, wheezing equals bronchoconstriction. Wheezing indicates bronchoconstriction. Reflect back to your previous lectures. Is the bronchial tree upper or lower airway? Lower.
Indicates what?
Bronchoconstriction. Wheezing indicates bronchoconstriction.
Does the wheezing come from the bronchus?
Mm-hmm. Yeah, when they narrow like in asthma, you start hearing that wheeze.
I used to think it was in the upper, I don't know why.
I have a name for that in the upper. And it's not on the screen. But I'll get to it here real soon. The last 2 words up there, rhonchi and crackles. There's another word that's not up there called rails, R-A-L-E-S. Rails, rhonchi, crackles. The National Registry likes to keep it simple, and so do I. Don't worry too much about raws and rhonchi and just go with crackles. Crackles are lung tissue. Crackles are going to be heard at the alveolar level. Crackles are going to be heard with fluid in the lungs. You're going to hear a snap, crackle, pop kind of thing, a crackling like a crackling campfire. Every time they breathe, you'll hear those. It'll sound like bubbles popping, if that makes sense. Go to YouTube tonight and look up these breath sounds, and you'll go, oh God, that sounds terrible. Okay, so please go out and do some research here. Rails and rhonchi are crackles' first cousin. All of them are down in the bases. All of them sound like Rice Krispies and milk. I think I could take 3 physicians and play a set of sounds and say, is that Rawls or Ronchi? And I don't think we'd get a unanimous 3. We may have textbook definitions of Rawls and Ronchi, but when it goes to applying that in the field, we will not know what it is. Let's keep it simple and just call it crackles. So crackles are in the bases of the lungs. They're down there where the alveoli are. Down there where the lung tissue actually is. Crackles equal edema. Crackles equal fluid. Crackles equal pus.
So Ronchi and crackles are the same thing?
For practical speaking, yes. Rawls, Ronchi, and crackles, that's all involving lung tissue, hence alveoli. Okay? But like I said, we can get into some type of argument of whether it's Rawls or Ronchi. Just keep it simple. It's crackles. Registry will use crackles. So if I'm reading a test question and it says, lung sounds indicate crackles in the bases, that tells me that I have fluid in the alveoli. Assessment of your patient reveals wheezing. That tells me I have bronchoconstriction. One more. Those two were lower. This one will be upper airway, which means above the vocal cords, and the word is stridor. S-T-R-I-D-O-R. S-T-R-I-D-O-R. Stridor. Stridor sounds like a more higher pitched, almost like a barking, almost like barking.
And you said upper?
It's upper. It's often found with things that are obstructing the upper airway, like a toy in a kid's throat. Swollen tonsils to the point to where you can hear it. Swollen tongue, burned upper airway. The point is, stridor is upper airway. Wheezing, bronchial tree, crackles, deep lower airway. That's where the registry is going to be at, y'all. So, you're like I said, if you really got to researching this, you'd come up with no fewer than a dozen lung sounds that basically fall in one of those 3 categories. And there's no application for that in emergency medicine. There's application for that somewhere, but not in emergency medicine. I don't care over semantics between Rawls and Ronchi. So much so, if you had me match the definitions right now, I couldn't do it. I'd probably miss it. Keep it simple. It's crackles. You can read your book if you want further explanation on that. So if I go back to here, and in here I hear wheezing, then I know this man's suffering from bronchoconstriction, right? Some form of emphysema, some form of asthma, something. We've already talked about the hypoxemia. Guys, I'll keep throwing that 94 out there because that's the cutoff. Would you like to know how we got to the 94 and why that's the cutoff? Damn, Billy.
I mean, I do.
You can do without it?
No.
Okay.
I mean, sure, we'll skip it for everybody's sake.
Well, I'm under the concept, I never want somebody to go, I never heard of that before. Didn't you go to EMT school? Where'd you go to EMT school? I went to Grayson.
Everybody told us 90 to 92.
Do what now?
They always told us 90 to 92, so that's fine.
You need to ask that person, do they know anything about the oxyhemoglobin dissociation curve?
That was a big word.
That'll shut them up. That'll shut them up. I know where you're hearing this from, and I don't want you to get confused between what you're hearing and what I'm saying, and I'll explain here in a minute. So if I take a graph, this is a Cartesian coordinate system, XY axis, kind of stuff, x-axis, y-axis. If the x-axis represents the percentage of saturation of the hemoglobin, and the y-axis is my pulse ox reading, my pulse oximeter.
What's X again?
X is the percentage of saturation on the hemoglobin. Let me draw this curve as accurate as I can. And then it just kind of flattens off. We're up here at 100 here. If you were to go down this curve, let's just say this was a mountain ski slope, and you were skiing down this slope. At some point on this slope, you would start accelerating really fast. In other words, the curve just really takes a nosedive. In math, you call that the point of the tangent line. There's some line here that just goes by, where is that the most steep? Where does it become the most steep? And the answer is it becomes the most steep at 94. So if you were going down that mountain at 94, it's kind of like the crest. It's like I have broken over. And you know what I'm talking about on that? Can you imagine? Going along and then all of a sudden it just got really steep. Kind of like the roller coaster. You're on a roller coaster, you're like, this is cool, man. And it goes, that moment you go, oh, that break over. Well, in this curve, it breaks over at 94. Which means the percentage of saturation here is somewhere, 90 to 100 in this range. Once you break over, man, it starts falling quickly, doesn't it? It starts falling quickly. And that's why 94 indicates the hypoxic point of the curve. Now, to your point, you guys are hearing things like 90, you're hearing things like 92. What that's indicating is when it comes to treating maybe a chest pain patient, the American College of Cardiologists want you to keep the O2 status. If you got it to 90, that's good enough. I told you that too much oxygen is bad, didn't I? Too much oxygen is bad. When we have strokes, when we have traumas, when we have heart attacks or myocardial infarctions, do I have damaged cells in the body? We talked about damaged cells yesterday, necrotic cells, dying cells, cells in some form of anaerobic metabolism. Are they stressed? Those stressed cells chemically are excreting something called a free radical. Chemically speaking, we're creating free radicals, which means there is an electron displaced from its orbit, and we got a free electron out there that is dangerous. Because if that free electron finds something, an actual small, very small, microscopic, atomically speaking, nuclear bomb goes off. Do that on a large scale and you got a nuclear bomb. But you got one free electron out here that's floating around waiting on something to marry up to. And it will find something. It can find one of two things. It can find an oxygen molecule, or it can find what you see in the stores sold all the time, an antioxidant. So if I give the patient more oxygen than needed while they have free radical formation occurring, I'm going to get the little bomb. And that's going to promote tissue death, tissue injury. Free radical formation is not good. Another way to explain this, or another part two of this, is in studies of heart attack victims, and we do this in pigs. Pigs' hearts and human hearts are almost identical. We can induce a heart attack in a pig and give that pig 100% oxygen, and the coronary vessels that we want to open up are actually becoming more constrictive in a high oxygen environment. Same thing happens to stroke patients. A stroke is a heart attack of the brain. There's no difference. It's just a heart attack in the brain. I want those arteries to be flowing blood to the brain tissue. High concentrations of oxygen constrict them. And I have free radical formation. and oxidative injury to go along with it. Trauma patients, do they have cell damage? Yes. Yes. I really worry about this in that trauma patient. That's why you're hearing 90 and 92 is like, that'll get them by till we get this resolved. Us in the field, our current standard is 94. Because even at 90 and 92, you're on this side of the slope, but you're also in a medical facility that's correcting the issue, hopefully. That makes sense to you? Over here, you don't have the leeway you get. You got to be a little more cautious in the field because you're not really doing. But to both points, I don't want to put it all the way over here. Well, obviously it's not needed because the curve's pretty flat anyway, isn't it? There's not much difference between here and here. Percentage of saturation is percentage of saturation. So where's all the extra go? Where's the hyperoxia go? Well, it just floats around waiting for a free electron. Not good. Answer your question, Billy?
Yeah.
You in the hospital, does that help? Understand where that comes from? But what's the cutoff line for us? 94. I mean, we talk a lot about hypoxemia or hypoxia. I think it's worth noting that we should also avoid hyperoxia at the same time. Avoid hyperoxia. If I go by the adage, give the patient what they need, and they don't need oxygen, then why would I give it to them? Why do some of our peers still do that? Oxygen provides comfort, doesn't it? Yeah, I've heard that one before. No, Valium does. THC does. Alcohol will to some degree. Oxygen doesn't. Why'd you give them oxygen? They were short of breath. Oxygen never corrected shortness of breath. Beta 2 agonists do. Why'd you give them oxygen? What's going to hurt? Well, it could hurt a lot. It could hurt a lot. You know one of the most alarming reasons we give oxygen? It's the same reason we take blood pressure sometimes. There's something to do. You know how I can tell a rookie EMT? They're the first ones to grab a blood pressure cuff and get me a blood pressure. I mean, they won't even ask them a question, but they'll come, I got 124 over 68. And you're like, awesome. Good for you. Do you know the patient's name? Do you know the chief complaint? Do you know why you're here? It's something to do. I know how to do that. I'll do that. I think we had a question on the board. How do I stay out of the way? How do I approach a scene? Something to do that. I don't know what else to do for them, but so I just gave them oxygen. That's an act of omission, isn't it? That's when I do something when I had no indication to do it. Can you see free radical elimination? Can you see oxidative injury? Not today. Not today. But when my stroke patient never regains the ability to speak, did I have a part in that because I gave them 100% oxygen? You could have. You could have. Did I worsen their heart attack by giving them 100% oxygen? You could have. They were 96 when you picked them up. Why did you give them 100% oxygen? It's the good green gas. I thought I should. Oxygen is not the cure-all, guys. We've been led to believe that it is. If you can define this term, I will leave the presentation and talk to you about Canvas and clean up a few other things. If you can define this term. Gus wants to try. He's over here just retching in his seat like, please call on me. I know what this is. Yes, Derek?
Does it mean you have too much carbon dioxide?
It has too much carbon dioxide. Very good. So we'll pick up here tomorrow. I'll exit out of this and go into Canvas and clean up a few things and go from there. Gus, why I mean, why would there be a lack of or too much carbon dioxide? Huh? Oh, look what's in my inbox. What is tidal volume? We may watch that tomorrow. Let's go over here to Canvas. While I'm doing this, somebody's got a question on the parking lot. I'm really liking how that's working out, and that question is pertaining to, as a Grayson student, do I have free access to Microsoft 365? You familiar with who wrote that question? And the answer is yes, you do. Did you get your answer yesterday from Regan? So that goes for any of you. Regan, MicrosoftOffice365.com.
Yes. If you go to MicrosoftOffice365.com and use your Grayson credentials, the Grayson email, not the login name, but the whole email address, and your Grayson password, it should allow you to sign into Office 365. On the front page, up in the upper right-hand corner, is a link that says installs or more. And if you click on that link, then you can install it on up to 3 systems. So if you have 3 computers at home, you can install it there. If you can't get in for some reason, if you can't get into Microsoft, first of all, try it from your My Viking portal. There should be a tile in your My Viking that lets you click on it and take you right there. If you can't, you need to turn in a ticket with IT so that they can fix your login and put you on the list for Office 365. But yes, you do have that at the Grayson student.
I would get it if I were you, especially if you're going to paramedic school, because you'll write a lot of stuff. So if you go into Canvas 1501, the course we're in right now, I have turned on Module 3. We're in week 3. By the end of the week, I'll have Module 4. Team approach to healthcare and patient assessment. But Module 3 is pharmacology and airway emergencies. That's what we're doing today. I've sprinkled in a little pharmacology. So with that being said, here is your homework assignment. It's a fun homework assignment. It's relatively easy. I would try different search engines to see if you get different results. And I'll also give you a clue where a great wall poster is. It's over in the science building. On the second floor of the science building, there is a wall poster that's basically the same thing I'm telling you. I want you to find the top 10 most commonly prescribed drugs, and I want you to find the top 10 drugs by profit. And they may or may not be the same, but every year I give this assignment, it changes because something new has hit the market. What do we expect to find on the top 10 list this year that probably wasn't there last year?
Ozempic.
GLP-1 agonist.
What was the second one?
Drugs by profit. Pharmaceuticals by profit.
First one was top 10 used.
Prescribed. Top 10 prescribed drugs. And then the second one, give me the top 10 by profit. In our exercise tomorrow, we're going to relate them to the 4 horsemen. Thursday's lab will include airway skills, oxygen skills. There's a lot. It's a technical lab. There's a lot of manipulation and a lot of putting together of equipment and lefty-loosey, righty-tighty, gasket seals, oxygen burning down the house, tubings, touching mannequins, putting things in the mannequin's airway. It'll be other people. It'll be other people. Yeah. I'll go ahead and mention it now in case I forget tomorrow. I took it for you and I owned up to it because I told you could, but you can't wear shorts Thursday. You got to wear pants. So, sorry. Not my rule.
Where do we turn this assignment in that?
You just bring it to me tomorrow and we'll have that open conversation with it. That way we can compare it to everybody's. Any question on this one? If not, let me go to 2305. Operations. Let's see what I have turned on for you here. I smell food. So 1 is on, 2 is on. I'm going to activate number 3, and it looks like you guys get to go back to FEMA and do ICS 700 now. This is in the operations class. I don't think I've seen any responding to triage turned in yet. Am I wrong? Am I wrong?
Is that just a quiz?
No. No, it's actually, you have to write out a response. It's a scenario with, I think, 9 injured people. You have to sort them and deliver them to the appropriate hospital based upon where they are located. And that's going to have you look up the hospital capabilities and things like that. It's kind of cool. I do it, you may say, you're doing it a little bit early. We'll revisit it later in the course and you see how your minds have changed over that. That's kind of a good idea to show you what your human reaction is as a bystander versus what your reaction is as a trained professional. Do I have any Star Trek fans in here? Really? The movies?
No.
You're not a Star Trek fan if you didn't watch the movies.
The original trilogy?
You ever watch the movies?
No.
You ever watch the one, The Wrath of Khan?
Oh.
Star Trek, The Wrath of Khan?
With James T. Kirk?
Uh-huh.
Seen it.
Do you remember when Spock went into the nuclear reactor area and contained it so the ship would survive? You remember that? And he went to the glass and him and Kirk were sitting here talking.
Yeah.
Remember when he grabbed Dr. McCoy on the way in and done the old mind meld with him? And then Kirk said, "Spock, why did you do it?" You remember his line after that? Because if you do, that's triage. The needs of the many outweigh the needs of the few or the one. You get that?
I remember saying that.
You don't? Do you remember me saying it?
Well, I remember the scene.
The needs of the many outweigh the needs of the few or the one. Triage is funny because our rules go out the window. I'll take care of the salvageable. Our patients now get these terms salvageable, non-salvageable. And that's against our human nature. What we would normally work on sometimes in triage, we walk by. You want a great example of a national registry test question? A man walks out of a burning house. He has third-degree burns over 60% of his body. You have multiple victims. What color of tag does he get? Black. Why? Black means dead, but he walked out.
His skin is like, he can't.
You're not going to survive third-degree burns over 60% of your body. Go have him stand next to the morgue. While you're walking, walk on over there. If I try to treat him, I'm going to miss the 4-year-old with a second-degree burn to the face that needs my resources. It's tough, isn't it? It's tough. It's almost like, you got to be so whatever to do this job. I know. Any questions in Canvas? Riley, was there anything else?
I think so.
And everybody's here today.
Yeah.
Do y'all have any questions for me?
What's that quiz show?
Transport operations quiz? I can find out. I can find out. Manage due dates and assign to. It looks like it's open. I haven't closed it off on you. Darn. Thank you for reminding me. I'll close that here in the next 25 minutes. No. Yeah. What else? Oh, I know what it was. I was going to talk to you about